Good afternoon. Welcome back to our webinar series entitled Frontline Report, Autoimmune Liver Disease and the Pandemic. This series of webinars are made available via collaboration between the Autoimmune Hepatitis Association and the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. I'm Craig Lammert, the Executive Director for the Autoimmune Hepatitis Association and an adult hepatologist at Indiana University. I'm excited to welcome you to the fifth webinar in our series entitled COVID-19 in Children. Quickly, a disclosure from the AIHA. This webinar series does not replace your primary physician, gastroenterologist, or hepatologist. We cannot diagnose, treat, or manage symptoms associated with AIH. As indicated by our title for this webinar installment, we are going to zero in on key issues surrounding the novel coronavirus pandemic, largely specific to children. We are very lucky to have these three physicians from multiple medical centers joining us today. They are all a part of real-time scientific teams seeking to learn more about how SARS-CoV-2 affects kids in general and how it affects kids with autoimmune liver diseases. You'll learn more about our guests from our moderator. Today, that is Dr. Amy Taylor. Dr. Taylor is a pediatric hepatologist at Cincinnati Children's Hospital, where she is also a part of the Center for Autoimmune Liver Disease. Thank you, Dr. Taylor.
Hello, I'm delighted to introduce Dr. Ashish Kumar, who will be speaking about multi-system inflammatory syndrome in children. He is a professor of pediatrics at the University of Cincinnati and a physician scientist in the Division of Bone Marrow Transplantation and Immune Deficiency at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Thank you so much for joining us today.
Sure, it's my pleasure to be here.
So we've been hearing a lot about multi-system inflammatory syndrome in children in the press. Can you give us some insight into what pediatricians were noticing in areas with COVID-19 outbreaks and how this came to be?
Yeah, I think the first reports came out of the UK where they recognized that they had several children who were coming in with the prolonged fevers and abdominal pain. Many of them initially had thought to have had symptoms that resembled appendicitis, but over time they started to recognize that the prolonged fever and some of the laboratory markers such as the inflammatory markers of CRP, sed rate, started some people into looking deeper that they had seen similar features in children with Kawasaki's disease, particularly the atypical type of Kawasaki disease. And lo and behold, when they looked for the hallmark of the vasculitis or the coronary artery abnormalities that are seen with the Kawasaki disease, they started finding those in these children as well. So it started off in Europe, and then now we know that in many other parts of the world, wherever there's been these epicenters of COVID-19, children have been diagnosed with this multi-system inflammatory syndrome.
It's very interesting to be able to see kind of the development of this in real time and trying to learn and understand as things are progressing. You know, Kawasaki disease is something that we learned about in our pediatric medical training. It's been surprising to also see this in the news, and I know you referenced it as well. You know, what is Kawasaki disease and how is the current SARS-CoV-2 syndrome related, I mean, if at all?
So Kawasaki disease, it is still a little bit of a mystery. We do know that it is an inflammatory vasculitis where the small to medium-sized blood vessels, particularly the arteries in the heart, the coronary arteries, get affected. They get inflamed and swollen, and they balloon out, which is called an aneurysm. We know that it is an inflammation of the blood vessels. What we don't know is what causes that inflammation. What is it that brings it about? There seems to be, particularly since this is more frequent in Japan, it has been best studied there. There seems to be a seasonal variation where it is more common in the winter times, and the thought is that there is some pathogen that remains to be identified that sets off, or that in response to that pathogen, perhaps there's an immune response that attacks the lining of the blood vessels, the endothelium, which then leads to the inflammation of the blood vessels. So in a nutshell, we know that Kawasaki's disease is inflammation of the small to medium-sized blood vessels, and there's fever and inflammation associated with it. That's how we best understand it. And in response to the inflammation, many different therapies have been tried. And unfortunately, our knowledge of Kawasaki's disease has not increased more in the last 20 years. That's when I first became aware of it, when I was a resident myself. We still just know this much.
So what is the current thinking of why we're seeing this inflammatory response in kids with SARS-CoV-2 infection?
Again, unfortunately, it remains one of those mysteries. Perhaps it is possible, perhaps, that the virus itself infects the endothelium or the lining of the blood vessels, which then, of course, anytime a cell is infected, it invites an attack from the immune system. So perhaps in response to the virus directly infecting the endothelium, the immune system then comes there to rescue the endothelial cells. And in response to that inflammation, you get ballooning of those blood vessels. Or could it be that the immune response that has been brought about because of the virus elsewhere, the blood vessels happen to be collateral damage, that they're just innocent bystanders, that the inflammatory response from the immune system in response to the virus is such that it ends up causing damage to the blood vessels. And then, of course, a third possibility, and all these are just hypotheses, speculations on my part, is that the immune response that is directed towards the virus accidentally also recognizes some protein or some marker on the endothelium or part of the blood vessel, and then ends up attacking it in response. What we must understand, though, that this is a very rare phenomenon. Even in the report coming out of the one of the epicenters in Italy, they estimated that of all the children who got COVID-19 or got infected with SARS-CoV-2, it is only about 1 in 1,000 children who came down with this multisystem inflammatory syndrome, which is a good thing that it is rare, but it also then poses a challenge that because it is so rare, we don't have the large numbers of patients that we can study and from whom we can learn the pathophysiology and then understand what types of treatments we would use.
It is reassuring that it's relatively rare, especially, you know, the information we're seeing in the press, and that it's helpful to kind of keep that in mind as we're talking about it for sure. You know, so can you explain what factors contribute to diagnosing children and teenagers with this syndrome? You know, what are doctors looking for? What kind of tests and things might kids have done?
Yeah, so all patients with, well, I shouldn't say all, majority of patients with COVID have had fevers and respiratory symptoms. What sets these children apart is that they have a prolonged or several days of fever, and then many of them have abdominal symptoms, either abdominal pain or vomiting, similar to what we see in children with appendicitis. And then as you start looking, we find that they have markers of inflammation, which is true with majority of patients with the COVID-19, where they have elevated levels of CRP and sed-rate, and then this other new inflammatory marker, new for everyone else, not for us, ferritin, where the ferritin levels are quite high. And then we start finding that they have maybe some mild anemia, some elevated neutrophil levels, but it's a relative neutrophilia. That's the technical way of describing that. The neutrophil counts are higher. The lymphocyte counts are actually lower, which is true for a majority of COVID-19 patients who are sick, admitted to the hospital. So the constellation of these findings of prolonged fever, abdominal pain, and then comes the most serious part, and that is effects on the heart. The heart function, the heart muscle function starts to decline, and then that leads to decreased perfusion or circulation of blood to the tissues, which is manifest as low blood pressure or hypotension. And if you don't get enough blood circulating to your vital organs, then they start to malfunction. Specifically, the kidneys kidney dysfunction has been described in many patients, which seems to all which can be traced back to the reduced perfusion caused by reduced activity of the heart muscle. And so those things tied together make up this multi-system inflammatory syndrome. And in majority of the children, this seems to either follow an acute infection with SARS-CoV-2 or at the same time, although there have been about 10 to 20% of children in whom there was no evidence that they ever had exposure to SARS-CoV-2. So how much of SARS-CoV-2 is to blame, it still remains an open question.
That's helpful to kind of help to understand, how the processes and how it affects kids and kind of their overall, body systems. We recognize it's relatively rare, but are there any underlying conditions that seem to make it more likely for certain kids to develop this, or do we not know yet?
Yeah, unfortunately, we don't know. We presume that the fact that it is so rare, one assumption could be that those children who get it must have some underlying condition that predisposes them to get this inflammatory attack. But so far, we have drawn a blank. And that just goes to show about how much we don't know. And this is different than what we do know about the more typical clinical syndrome that happens in adults who get infected with SARS-CoV-2. Those adults who are elderly, who have underlying conditions such as diabetes or heart disease, are more likely to suffer a more serious illness. None of those seem to happen in children, so we don't know. One other thing that distinguishes this syndrome from the disease that we call Kawasaki disease is that Kawasaki disease affects younger children. In fact, the more serious ones happen to be less than a year or sometimes even less than 6 months old. On the other hand, this multi-system inflammatory syndrome appears to affect older children. They are actually usually around the age of 7 to 8, sometimes even young teenagers. So even though this multi-system inflammatory syndrome shares features with Kawasaki disease, there are some things that are not common to the two syndromes.
So given all of that, what we know about it and kind of how it relates to other more familiar syndromes and inflammatory syndromes, what are some potential treatments that they're trying for kids with this?
Yeah, unfortunately, because this is happening in real time, this is a moving target, if you will. Since we're not familiar with what the pathophysiology is, what the disease is, what the right treatment is also a little unknown. Given the fact that it resembles Kawasaki disease, the first thought that physicians who encountered these patients was to try the same treatments that have been used in Kawasaki disease. So the first therapy or the best well-known therapy for Kawasaki's disease is high-dose gamma globulin, IVIG. Now, there is about 10 to 20% of Kawasaki disease patients who do not respond to IVIG. They have what's called a refractory form. And turns out that the children who have the multi-system inflammatory syndrome associated with COVID-19 display features that predict that they would be resistant to IVIG. Now, that does not mean IVIG should not be used. Almost all children are being treated with high doses of IVIG. Fortunately, it's a relatively benign drug by itself. It does not have too many serious side effects. And so the potential benefits outweigh the minimal risks. But it's possible, and most of the treating physicians are already expecting that children will not respond to IVIG alone. So they're adding corticosteroids to IVIG because that is what has been used in children who were resistant to IVIG in Kawasaki disease. So that is the treatment approach that is currently being utilized. Whether this is the right one or not, I think only time will tell. But in real time, as of now, the data that we have currently, that is how people are managing them.
And that's helpful to know, to kind of have a blueprint of a similar, possibly related disease to, in real time be able to inform the treatment for these kids. And I know that, physicians, across the United States and across the world are learning in real time and sharing and communicating with one another about findings in these patients.
Yeah.
From what we know, can you share some information on how kids have done after developing this inflammatory syndrome and how they're responding to these potential treatments?
Yes, fortunately, the disease itself is rare, and the other fortunate part of that, majority of the children have had a complete recovery after suffering this, what seems to be a very serious inflammatory syndrome. In the first publication of a large number of patients, when I say large, I'm talking about 10 children from Italy. In their report, they reported 10 children, and all 10 of them made a complete recovery, which is quite comforting to know. But just like everything else, there are exceptions. I'm aware of at least one child, I forget in which country in Europe, who did not survive. And I have heard of reports in the US about of many children who had it, but majority of them have made a complete recovery. So fortunately, it is rare, and fortunately, majority of children seem to make a complete recovery.
That's great to hear that, that it's relatively rare and that most of the kids who get it are doing better from what we can tell. Especially, is there anything else that parents and kids should know about this, or anything else that they should be aware of for this? I know a lot of our families and our patients are already, have autoimmune hepatitis or other liver-related diseases, primary sclerosing cholangitis, and I know that there's already kind of a high alertness, I think, that's out there. Is there anything else that they should be aware about this, about COVID-19 in general?
I mean, I think the most important aspect about this disease and the state in which we are is to recognize that we are still learning. What we may think is the right thing to do today, 6 months from now, it may be proven that actually it was the wrong thing to do because we just don't have the data. Now that does create a huge amount of uncertainty and anxiety amongst the minds of parents, physicians, all of us, that we just don't know what to do right now because this is a completely uncharted territory. And so I think most important to keep in mind is that we are learning as we go along, and that a majority of patients actually are recovering, especially children. Majority will recover, and that although we are desperate, panicking does not help. What helps is using science and data in trying to make decisions. And so majority of people who are probably going to be watching this webinar are families whose children are already sort of immune compromised because they're on immune suppressive drugs. And from what we have seen is that our families, similar to these families, they're already so aware and so aware of germs and are so conscious of taking care of or preventing infections in general that it has almost become second nature to them. The things that the rest of the world is now doing, frequently hand washing, staying away from sick people, well, most of our families have been doing that their entire lives. And so that's a good thing, and those practices must continue. And we hope that as time goes on, we will learn more and use data to decide how to treat these patients. In the meantime, we will go with what we know, knowing that it may not be perfect. It's based on limited experience, but that's what we have.
That's really helpful information for patients and for families and for parents. Dr. Kumar, thank you so much for your time, for sharing your experience and sharing this information with us. We appreciate your expertise and your words. It's encouraging to know that as a scientific community and as a larger community with patients and families, that we are learning from this and really kind of putting science into practice to be able to treat kids who, the kids who develop this rare complication of COVID-19. Thank you so much for your time today.
Thank you. Thank you. It was my pleasure. Thank you. Bye-bye.
Thank you, Dr. Kumar and Dr. Taylor. Emerging reports have provided evidence that this multi-system inflammatory syndrome is also now turning up in those in their early 20s as well. There's been some concerns in the community of adult doctors with these observations for a few reasons. One, these very early reports of older adult patients with multi-systemic inflammatory syndrome have tended to have more severe course than what has been observed in younger patients. And two, it may be underdiagnosed, since many of us doctors outside of the pediatric setting, myself included, have never seen or treated cases of Kawasaki disease, the inflammatory blood vessel disease that looks similar to multisystemic inflammatory syndrome associated with COVID-19. Much like everything we have seen with COVID-19, we hope with data collection across the world, we will continue to learn more about these rare complications. This form of international collaboration is critical to advance our knowledge. Dr. Taylor will next interview two doctors that are doing just that, collecting information about COVID-19 in kids with liver disease and history of liver transplantation. Dr. Taylor.
Dr. Lammert, I'm so glad we have the opportunity to speak with Drs. Kehar and Abel about a collaborative effort to create an international registry to better understand outcomes of COVID-19 for children with chronic liver disease and liver transplant. Dr. Mohit Kehar is a pediatric hepatologist and assistant professor of pediatrics at Queen's University in Ontario, Canada. He is representing the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN, which is a pediatric medical society supporting the registry efforts. Hello, Dr. Kehar. Thank you for being with us today.
Well, thanks for having us.
I'd also like to introduce Dr. Noel Abel. She is a pediatric hepatologist and assistant professor of pediatrics at Stanford University and Lucille Packard Children's Hospital in San Francisco, California. She is representing the Society of Pediatric Liver Transplantation, or SPLIT, a pediatric liver transplant medical society also supporting the registry efforts. So this registry for children with chronic liver disease who developed COVID-19 was a joint collaboration between the two pediatric-focused organizations, NASPGHAN and SPLIT. Dr. Kehar, how did your team collaborate to develop this registry?
Yeah, so because in these current difficult times of COVID pandemic, there was an interest among physicians, parents, patients that how this current pandemic, this infection is affecting or impacting the children who have had chronic liver disease or who have had liver transplant. And it was also important to understand how our colleagues are managing these patients so that community-wide we can learn from each other's experiences. You might be aware that there are other registries out there working on the same principle, but they include mostly adult patients. And if you see the data, the median age is over 50 years. And as you know, the causes of chronic liver disease are so different in adult and children. And over the past few months, we have now noticed that COVID impact children quite differently. So we cannot extrapolate the adult data in pediatrics. So that's how NASPGHAN, that is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, and SPLIT, that's the Society of Pediatric Transplant, we united to form this pediatric-specific registry. And our intent was to collect and disseminate the experience of our community, and it was a great collaborative team effort from both the societies. And as they say that alone you can do so little, and together you can do so much, right? So both of the society had worked hard together, this common vision of better understanding the natural history, the impact, and the management in our children, so basically in our definite population. And I would say that this work would have not been possible without the guidance or mentorship of Dr. Mercedes Martinez, who is the hepatology committee head of NASPGHAN, Dr. Vicky Ng, who is the president of SPLIT, Dr. Steve Liberator, who is the chair of SPLIT Quality Improvement and Clinical Care Committee, and the continuous support of Dr. Abel.
It sounds like it's a truly great collaboration, and we're so glad that you guys were able to work together and put this together for providers and also for patients and families.
Sure.
Dr. Abel, what were important considerations the team made in including kids who have received a liver transplant?
Yeah, so I think most importantly, we wanted to gather data that would help answer the questions that our patients and their families were asking their liver teams. And we wanted to be thoughtful not only in creating a liver registry for children, but we also wanted to create this community where we could share knowledge that we're gaining in real time so that any liver doctor or infectious disease doctor or any other doctor really, and even patients and families as well, could access this data. And so when we thought about special considerations for children with liver transplant, we had known some things from the experience of our Italian colleagues, for example. So they had already had a report from one of their centers where they followed 700 children that received a liver transplant, and 100 of those were transplanted for autoimmune liver disease. And they had been reporting that none had developed lung disease despite 3 testing positive for COVID, And their assumption was that there were certainly more because they were in an endemic area that just didn't happen to be tested. So their conclusion was that immunosuppressed patients may not be at increased risk of severe lung disease compared to the general population, which was very reassuring to hear. And we wanted to continue to add and contribute to their early observations. And we also wanted to be thoughtful in how we should manage our patients with liver transplants. And similar to patients with chronic liver disease, we wanted to understand how other expert colleagues were changing immunosuppressive medications and ones that all may be familiar with, like azathioprine or Cellcept or steroids, and what we should do with those medications for our patients that became COVID positive. And we wanted to try to understand, does the liver become more inflamed during COVID infection? And for those that received COVID-specific medications, how did that impact their liver, especially in those who had had a liver transplant? And for those in this audience that have had a liver transplant, this may sound like a familiar problem. We also wanted to try to balance that. So as we thought about if a patient becomes COVID positive and we decrease their immunosuppression, we wanted to also make sure that we weren't tipping them into rejection. So it's always a fine balance, but we wanted to try to capture what others were doing and bring all of those voices together. And again, most importantly, we wanted to create the registry, but we wanted to create this community of those that care for patients like yourselves, including liver doctors, transplant surgeons, infectious disease doctors, just to get everyone in the room and just to hear everyone's individual experiences at their own centers.
You know, it sounds like it's a great effort to be able to understand, you know, who is being affected, how they're being effective, and what kind of treatments and what kind of medication changes, especially for patients who are on medications that may modulate the immune system, may be affected. So this international registry has been active for nearly 2 months, which is exciting. Dr. Kehar, how many children with chronic liver disease have you identified? And can you tell us a little bit about what types of underlying liver disease they have?
Yeah, so we just shared our week 5 report this morning with the community members, and I'm going to show you it later during this interview. And we have 16 patients who have been entered in the registry who have chronic liver disease without a transplant, and the median age of that group is 6.5 years. So the youngest patient in the registry is a 2-month infant, and the common liver diseases among these were biliary atresia being the most commonest. Then we have non-alcoholic fatty liver disease or NAFLD. We have 2 patients with autoimmune hepatitis, a patient with metabolic disorder, and some rarer causes like intestinal failure-associated liver disease.
That's quite a diverse group
Yes.
with underlying liver disease. Dr. Abel, how many children with a liver transplant have you identified? And can you tell us a little bit about the reasons that they underwent a liver transplant?
Yeah, so in the past 5 weeks, there have been 12 patients that have been reported to be COVID positive who had a liver transplant, and their ages range from 6 months to 21 years old. And the reasons for transplant were also diverse. So one had biliary atresia, one acute liver failure, one had a metabolic disorder, one had a liver tumor, and one had intestinal failure-associated liver disease. None of the patients were transplanted for the primary reason of having autoimmune liver disease, but one patient that was transplanted for biliary atresia later developed autoimmune hepatitis after their transplant.
That's helpful to know kind of the general patient population that is included in the registry as we kind of talk about, you know, how COVID-19 affected them and their livers. And along with that, Dr. Kehar, can you describe the effect of COVID-19 on children who have chronic underlying liver disease who haven't had a liver transplant?
Yeah, so far in our registry, we have 16 patients, and 8 of them needed hospitalization, and only 3 patients needed intensive care unit admissions. So far, we see that most of these patients recovered. 11 out of 16 patients recovered. 4 are still active in their disease course, and then fortunately, there has been no mortality reported. And 5 patients developed some ascites, that's some fluid, excess amount of fluid in the abdomen. 1 patient had a GI bleeding. And there have been, many patients have a bit of liver enzyme elevation, which is expected as, we know, there has been literature around that now. But we have to take in consideration that's a very small number of patients and the risk is evolving. So we may have a better understanding in due time, but so far there has been no mortality reported in the registry. And from an autoimmune hepatitis perspective, we have 2 patients and both of them recovered from their infections.
That's great to hear. And it's interesting, to kind of know about the disease course. And I'm glad to hear that so far, the kids seem to be doing well or recovering. It'll be interesting kind of in the coming weeks for us, to be able to find out how the kids who are still in their active treatment phase of it are doing for sure. And then Dr. Abel, what have you learned about COVID-19 infection in kids who have received liver transplant? Are you seeing similar types of disease as in kids who haven't had a liver transplant? Can you tell a little bit about what we've learned?
Yeah, so the first is sort of what the symptoms they're presenting with. So again, we had 12 patients who had a liver transplant that have been reported to be COVID positive, and some of them had overlapping symptoms, but one patient was asymptomatic. 3 had respiratory symptoms, so defined as like runny nose or congestion or cough. And 2 of those patients had said they felt like they had some increased work of breathing. 9 had GI symptoms, so diarrhea, nausea, vomiting. 9 reported fever. 1 had a sore throat, and no patients reported a loss of smell or taste. In regards to how many ended up needing to be admitted to the hospital, so 5 out of 12 did come to the hospital. 1 out of 5 of these patients went to an intensive care unit, and but they did not need a ventilator or sort of invasive means to assist their breathing. And that patient was a little bit different. They had also had an intestine transplant in addition to their liver transplant, and their intestine was very sick. But that patient was in the intensive care unit. In terms of how it affected their transplanted liver, 3 of the patients had very elevated liver labs, so about 5 to 10 times what we would consider a normal level. But all other patients actually kept normal liver labs throughout their course, with the caveat that our registry sort of captures one moment in time. But we do ask those who submit to the registry we sort of solicit updates from them to understand the total course for these patients. The 1 patient that was in the intensive care unit did develop a low albumin level, which our adult colleagues and others have reported as sort of a prognostic indicator. So that was the sickest patient that had a liver transplant and also an intestinal transplant in this case. And 1 patient had a liver biopsy, and their liver tissue was positive for COVID by an in situ hybridization probe. 3 patients did develop rejection, so 2 of the liver and then 1 for the intestinal transplant patient. And then in terms of how the strategies for how immunosuppression medication was managed, so 4 patients had medication stopped when they were diagnosed with COVID. And of these, 4 patients had stopped mycophenolate mofetil or Cellcept, and 1 patient stopped sirolimus. All these patients were on another immunosuppressive medication. So I'd say the overall approach from those that submitted to the registry was taking off a second medication or second agent if they felt like they could. And then the other side of that was keeping on 1 primary medication. So in most cases that was tacrolimus, in 1 case it was cyclosporin, and the doses of that were reduced. There were patients that were also on steroids, so 6 patients out of the 12 were on steroids, and all the individuals that submitted ended up keeping that same dose of steroids on.
That's really helpful to know, and really, really helpful for the community to kind of get a gauge for how to manage immunosuppressive medications, especially in light of, many of those are the same that we're using that patients who have autoimmune hepatitis are on as well. And so that may be an analogous kind of treatment strategy, in terms of dose reduction, potentially, depending on the case. So that's really helpful to know. It's interesting to also think about what types of other treatments kids are receiving. There's lots of clinical trials and things like that for especially in the adult population. But I know that you guys are also learning about how providers are treating kids with COVID-19. So Dr. Kehar, can you tell us a little bit about what types of treatments children received? And did you notice any differences based on the disease severity or what their underlying liver disease was?
Yeah, so I would say that majority of patients didn't receive any specific COVID-related treatments. So 9 out of 16 patients didn't receive any specific treatment. And we didn't see any signals that any particular severity or etiology is driving towards any specific treatment modality. So I'll show you the registry which we shared today. So this was the week 5 report which we have shared today this morning, and specifically about the COVID-related treatments. There were 3 patients in the chronic liver disease group who received hydroxychloroquine and azithromycin. 2 received IVIG, 2 received steroids, and there were single patients who have received multiple treatments like azithromycin standalone, tocilizumab or sarilumab, that's an IL-6 inhibitor. 1 patient received convalescent plasma, and 1 patient each received anakinra and eculizumab. This is what has been reported so far, and similar pattern has been seen in post-liver transplant patients as well. Most of them didn't receive any particular treatment for the COVID. There was single patients who received azithromycin, 2 patients received hydroxychloroquine, 1 patient had IVIG, and 1 patient received favipiravir.
That's interesting. It looks like it's a combination of, you know, of quite a wide variety of different types of treatments, including medications that affect the immune system, kind of called from the biologic class, right?
Yeah. And there have been patients who are on multiple agents. So there have been patients who were on hydroxychloroquine and steroid. There were patients who were on like 4 types of agents, depending on the case.
Yeah, it looks like some antivirals there too. That's very interesting.
Yes, and as you can see, most of the patients from a respiratory support point of view didn't require any additional support. There were 2 patients in this chronic liver disease group who required ventilation. 1 required high frequency ventilation as well, but most of them have recovered from their COVID infection.
That's very helpful to see, kind of, and with there's a lot of information in a page for sure, and it's great that you're able to add, you know, the pending information for patients. You're able to kind of update it, recognizing that each of these reports is a snapshot in time, but it's wonderful to be able to kind of follow, to kind of see how kids are doing within the course of their infections. Right. Dr. Abel, I did want to talk a little bit with you as well. It looks like that overall after liver transplant, you know, you mentioned kind of the rejections, but the kids seem to have done pretty well. You're not seeing pretty significant signs of complications from their transplanted liver.
Yeah, absolutely. And I should have mentioned there have been no reported deaths in patients who have had a liver transplant that have been COVID positive to our registry. And then similar to what Dr. Kerr was saying about terms of treatment. So we had 3 patients that were treated with hydroxychloroquine, 1 with azithromycin, 1 with intravenous immunoglobulin. 8 patients have recovered from their COVID infection. 4 patients are still either in the middle of their COVID course or we're waiting further updates for those that submitted to the registry. But a great overall, we're again grateful that there have been no reported deaths and others seem to be recovering well.
Yeah. Well, this is wonderful to be able to have an international registry for patients and for families and for providers to kind of know in real time or nearly real time how kids are being effective, and be able to have, you know, some information on how the treatments and how kids are doing with these treatments. You know, you mentioned building a community for providers, but also for patients. You know, if families wanted more information about this, is this information publicly available? Are there places that they could get more information?
Yes, absolutely. It's available on the North American Society of Pediatric Gastroenterology website under the COVID resources section. And we have weekly reports being placed there, which anybody can access.
Yeah, and same for the Society of Pediatric Liver Transplantation website, and we'll provide both those web addresses to you guys as the organizers, but it was really important to our group to make sure that this was always publicly available to medical providers, to patients and their families.
That's really great. Has there been what kind of feedback have you guys gotten about the registry?
Yeah, it has been amazing. People being very appreciative of the collaboration of the 2 big societies. And it has been an amazing effort, I would say, and providing weekly reports, basically a real-time data. So people are understanding in a better way how this thing is affecting our children.
And I think what I've been grateful for too is the community building. So, you know, at our center, as we've had COVID positive patients, it not only gives us, all of us, access to data to sort of help guide, but it also builds a community. So as Dr. Kehar shares through listservs through his society, and I share through listserv through my society, you're able to pick the brains of all those that are involved. So again, transplant surgeons, liver doctors, infectious disease specialists to sort of go through a case. So it's sort of, I feel like it's brought everyone together to sit at the same table and to be willing to go through these complex cases together to benefit patients.
Yeah, completely agree. Yeah.
Well, that's fantastic. And I being a member of these communities, are really glad to get the updates every week and kind of, go through the details of the cases and get to better understanding, to prepare as we, if we start providing care for patients with COVID-19. This has been an amazing collaboration with organizations, and thank you guys both so much for being here, sharing the information from the registry, as well as your experiences with it. We really appreciate the time that you guys have taken to be able to talk and enlighten us with all of this. So thank you both so much. It's been an absolute pleasure.
Thanks for having us.
We're so grateful for the invitation. Thank you so much.
Thank you for joining us for this special look into COVID-19 in children. I want to thank our collaborators, Dr. Ashish Kumar, Dr. Mohit Kahar, and Dr. Noel Abel. And special thanks again to our moderator, Dr. Amy Taylor. We hope you'll join us again in 2 weeks for our next webinar. See you then.